Welcome, everyone, to the World COPD Day. And this talk that I'm going to make and hopefully try to increase awareness about the disease that we don't know as much, that we should. I was watching the news yesterday, and they were talking about a very important disease. I'm sure you have someone in your family called Alzheimer. And Alzheimer is very well known. You're losing your memory. And by the time you make the diagnosis of Alzheimer, you've lost quite a bit of your cognitive capacity. COPD is the Alzheimer of the lung. You're not losing your memory, you're losing your breath. And it takes a while before you realize that you have the Alzheimer of the lung, that you have the COPD. And losing your breath can be as bad that you're not functional anymore. Losing your memory can be very bad because you're not functional anymore. Well, losing your breath is also and can also be very bad. Let's have an overview of COPD, chronic obstructive pulmonary disease. And let's breathe in the knowledge that hopefully this knowledge can translate it into action. Best care, best practice. What is COPD? This is an umbrella term, and people are probably more familiar with chronic bronchitis, emphysema. And that's what COPD regroup. It's a disease that goes from the large airway down to the small airway and then to the lung tissue, emphysema. It takes your breath away. Then there is obstruction, limitation to the air coming in, getting out. And there is also gas exchange abnormality. And when you have this tissue damage called emphysema. Plus, you have these flare-ups that are called exacerbation. Exacerbation is to COPD what heart attack, myocardial infarction is to coronary artery disease. Let me give you an example of one of the problems we may be facing now. It's the perception about certain disease as compared to other disease. You're a patient and you come to the emergency room with a chest pain and you're known to have coronary artery disease. What is going to happen? As soon that you get your feet in the emergency room, they're going to take you from the triage. They're going to move you in a special room with monitor and very well taking care of you. And as soon that they have everything stabilized, taken care, they're going to move you up to the coronary care unit. Take very good care of you, making sure when you leave the hospital, you have all the medication. They've saved your life first. You're alive. You're ready to go out. You're going to be on the medication to prevent further event, unstable angina, myocardial infarction. Again, you're a COPD patient. We don't choose our disease. You come to the emergency room because of a flare-up, a lung attack. What are they going to do with you? If they have a bed in a room, they're going to move you to that bed in a room. If not, they're going to put you in the corridor. Then they're going to put you the mask. And from that, they're going to try to see if they can manage in the next 24 hours that you can go back home. That's another time that Mr. or Mrs. So-and-so has been coming to the emergency room. Then the patient could be admitted on the regular floor. unless the breathing is so bad, okay, then he need some ventilation assistance. And then when the patient is going to go home, all his medication is going to be mixed up. Okay, then because we won't be taking care as much of the chronic underlying disease. If you have a diabetes and you come with very high blood sugar, then someone is going to take care of adjusting and making sure you have the right insulin, you are followed properly, you understand how to get your insulin, so on and so on. That's not the case with COPD. Awareness. Awareness has to go at different levels. The public, the patient, the healthcare system, including physicians. Is it important? The prevalence of the disease, almost 1 million of Canadians more than 35 years old. And there is 1 million that is not known. The face of the disease is changing. 50% of the patients are less than 65 years old. 65 years old and less, it's young. Sorry, I'm not talking of people of 18 years old here. I'm talking of the population in general. 65 years old and less, it's young. And that's more than 50% of the patient with COPD will be in that age group. What is the problem? The problem is that even though we have over 15% in a population study that have significant airflow obstruction from this bar graph here, the highest bar that you can see, you have at least 50% that are undiagnosed. And even in the group of gold 2, what we define here as moderate COPD, moderate because the airflow obstruction is 50% down, then you've lost up to 50% of your lung capacity. There's still over 50% of these individuals that remain undiagnosed in Canada. Isn't it like Alzheimer's? Because that's the same problem we have. We don't make the diagnosis early enough. These people are symptomatic, and we're going to see later on, how can we treat these patients? The lung attack are the #1 cause of hospital admission in Canada. Did you know that? Tell the administrator of your hospital. They should know that, and they should put the resources necessary to impact on that. If you had any disease that would be #1 cause of hospitalization, you would already have in place for cancer, for cardiac disease, for any other disease, you would have the resources in place. Now, it's still a debate, and should the resource be there, so on and so on. It's #1 hospital admit. What does it take? Third cause of death by 2020. You know, in India, it's the second cause of death. In China, in certain part of the country, it's the #1 cause of death. It's an important disease. If I'm asking you or ask a friend today, tomorrow, next week, give me the 5 more important causes of mortality in Canada, I beg you that COPD will not be part of that. I'm convinced 100%. I can put the money on the table. Risk factor, smoking, smoking, smoking. That's what we hear all the time. And it's true, smoking is still the #1 cause, certainly in North America, but it's not the only one. And even if it's the #1, a lot of these people have stopped or want or have tried or are still willing to try to stop, because smoking is not only a health habit, it's an addiction. And there is tons of other diseases that are related to poor health habit. What is the #1 disease that we have out there now in our modern society due to poor health habit, such as poor nutrition, poor quality, fast food, and decreased physical activity. It's obesity with a lot of complication, high blood pressure, diabetes, cardiovascular disease. What is the treatment for that? We tell people to stop to eat? No, sure, we tell people to eat better. That's for sure. But who is doing that? What is the impact of changing that? Then, do we stop treating these patients? Because of now, we still, a lot of our disease of the new century are related. They're chronic disease, non-infectious disease, and that's the disease that killed most people now are not the infectious disease across the world. Even in a country like India. Then, what about the face of the disease that is changing? It is changing. What do you see here? What is the face that you're seeing here? That is common to each of these pictures. Woman. COPD is not a disease of men only anymore. It's also a disease of women. How important it is in women. These are statistics from the United States. There's a lot of these statistics that are very similar to Canada. And what you can see here is the mortality in women and men. And you can see that in the last 20 years, 1980 to 2000, there's been an increase in mortality of 13% in male. Look what in female we have here. It's 200% increase. And it's getting very, very, very similar to what we see in men. And a lot of the habit, unhealthy habit, has been taken now by women, and they have the same disease. Do they have the same disease? That's one of the questions. 5% now in terms of prevalence in women and 4% in male. The prevalence is higher in women than it is in male. 500,000 women have been diagnosed, and over 4,000 die every year. What those numbers mean, really? 4,000 of this disease, 4,000 of another disease. It's been raising, and it's double the rate of breast cancer. And it's not to say here that diseases are not competing. Sometimes they are competing in the same patient. But at least it gives us some figure that we can say, wow, this is, sure, you may have a different age group here, but okay, the mortality is twice mortality of another disease that we wouldn't accept it as being acceptable. Smoking seems to have a greater impact on women's lung health also. We're not too sure. There's still debate. But there are some information that we have that where there is no debate. And one information that we have and we know very much as a fact is that for the same height, women have smaller lung and smaller airway. And that really is going to play to the disadvantage of women as compared to men. Because even though you're losing your lung capacity due to COPD, and that could be to a less degree or a similar degree than in men, the impact of that is going to be greater on the mechanical limitation of breathing, greater dyspnea, exercise intolerance, and poor quality of life. Then for the same work that a woman will have to do than a man, because you've been starting with a smaller lung, and if you're a susceptible smoker, for example, and you have developed COPD, for the same damage you're going to have, the consequence is going to be worse in women than it is in men. And that should be taken into consideration. There are challenges, and I invite people to have a look at this special edition in the Lancet of Respiratory Medicine. And there's been a commission on the care delivery COPD in the USA. And a lot of this would apply as well to Canada, even though we have different healthcare system. It's not only having a different healthcare system, it's all you implementing. And you're going to recognize that there are a lot of gaps, that have been identified, from the payer to the healthcare system, healthcare professional, specialist GP, other healthcare professional, non-physician, and also patient. And I will invite it. It's quite a substantive document, but it is some piece, okay, that you may want to have a look at. And in summary, many challenges would start with the primary care. This is where most of the patients receive their care. And it's not by the specialist, but it's in the primary care by their family physician. Over 50%, as I already mentioned, of these individuals are underdiagnosed. The diagnosis in primary care often is done without using the spirometry, and I'm going to come back to that. Patient access to disease state education. We have to provide the tool to the patient that the patient can live on a day-to-day basis, and not only when he sees his nurse or his family physician or his physician, because the disease is with you every day. Drug therapy, medication, the right treatment to the right patient, and the non-pharmacology intervention that I'm going to review with you also. And pulmonary rehab is one of the things that I'm going to emphasize and why this is important. And is there a gap there? There is a huge gap in terms of access, in terms of referral to one of the most effective treatments that you have to improve exercise capacity and quality of life. Care coordination. We wouldn't talk more about this issue, about how to coordinate the care between the primary care physician and the specialist. Transition between outpatient and inpatient and vice versa. Very important. Everything is not only about who you're seeing, who is done for you, and how the care are coordinated. And in chronic disease, this is becoming more and more and more important. Recognizing the disease, we're not talking here of screening a population. We're talking of targeting a group of people that are at risk because they've been smoking and they have a minimum of symptoms. And the test to make the diagnosis is still the spirometry, a very simple test. Why is it not done in so many patients? Would you make a diagnosis of diabetes without measuring the blood sugar? Would you make a diagnosis of heart failure, your heart failing, without doing an echocardiogram? Would you make a diagnosis of COPD without doing the spirometry? Yes, it's done all the time. Then there is a problem. We have to reset our mind in the way that practice has to be to the same level of quality for all chronic disease, which is not the case now for COPD in general. And I'm talking by experience. I've been in the business for the last 30 years. Exacerbation, the flare-up, the lung attack. We've been talking of that. We've been giving an example of how do we deal on an acute base. But what is the consequence of exacerbation? Impact quality of life, accelerate decline in lung function, increase morbidity and mortality, and #1 cause of hospitalization in Canada. What is the difference between lung attack and heart attack in terms of consequence? And if you look at the difference in those that are hospitalized for lung attack and heart attack, there's 20 to 40% that will die within a year. That's very comparable between the two. In hospital mortality rate for COPD, it's 10%. The same thing for acute MI. We have to stop to consider exacerbation as a simple bronchitis. You can keep using the term of bronchitis if you want, but if as a normal person without lung disease I have a bronchitis, I don't have the same disease than my patient with COPD that has a bronchitis and an exacerbation. That's okay, where a lot of the mix-up come from. Coughing, bringing up phlegm, being more short of breath, and they're always short of breath anyway. You're just a little bit more short of breath until you get to the point that some of these patients are extremely sick, need to be hospitalized, need some ventilatory support, and these patients are at the same risk of dying in hospital and in the year following the hospitalization than those that have heart attack. What about the pharmacology treatment? But every symptomatic patient merits a trial of a medication. But you have to be able to assess first properly that the patient has limitation. And that's not always easy. It's not always easy because the patient has adapted. What is the adaptation if you're short of breath? You're short of breath for a reason. And very often it's because you're doing an activity that triggers that shortness of breath. Then you stop to do that activity. To the point that the only thing you're going to do in your life is zapping a TV channel. And you ask the patient, how are you doing, Mr. or Mrs. So-and-so? I'm doing fine. You're not asking, what are you doing? You're asking, how are you doing? There is a difference between the question. If you're asking the patient, what are you doing? And the patient is doing nothing, it could be because it's a very lazy person, or it could be because that person became lazy because she had no choice. And you have to find out about that. The progression, it's insidious. Alzheimer of the lung, Alzheimer of the lung. Think about it. It's insidious. Then you can try treatment and improve symptoms. Yeah, but stop smoking. That's the treatment. Sure, if the patient is still smoking. Smoking cessation will not give you back what you have lost, but it's going to improve or help in a way a fast decline or slow down the fast decline that you had before. But symptomatic treatment are important, isn't it? It is for many chronic disease you're giving to prevent complications such as exacerbation as well. Exacerbation is a complication. If you have a heart condition, a renal condition, an eyes condition because of your diabetes, you're taking insulin to avoid increase of the blood sugar and feeling bad about it. That's the symptomatic part. And you're treating with insulin because you want to prevent the complication. You're treating the COPD with a medication to alleviate symptoms, and you're treating to prevent complication, the risk of having exacerbation. That can kill you. It's not, it's not a trivial outcome to die from something. And you would, most of the patients that I know, they don't want to die. They want to know if there is something that can be done, if we can alleviate symptoms, if we can improve them, before considering that dying is the issue for them. What are the non-pharmacology treatments? We're talking about smoking cessation, and everyone is convinced of that. The data are very clear. You want to impact on the progression of the disease. A lot of these patients have stopped to smoke. They still have the disease. You still have to deal with it. Patient education. Patient education is not only about knowledge. It's about providing the patient with the tool that the patient needs to deal and cope better with the disease on a day-to-day basis. That needs coaching. It's not something, you want to learn to skate. You're going to need to practice. You're going to need some coaching. You're going to fall. Through your experience, through somebody else helping you, you're going to learn to do something. And it's the same thing, you want to have this capacity of dealing better with the disease on a day-to-day basis, taking your medication, how to control your breathlessness, certain breathing technique, energy conservation. How can I do activity or exercise, doctor? I get out of breath. There is a way we can, and that's pulmonary rehab. Oxygen for some patients. It responds to very specific criteria. Vaccination. Have you had your vaccination? It's time. Those who don't have, put that down. Has to be one of your priorities this week and next week. Vaccination. It's easy. It's free for you. Lucky we are in our country. You should be vaccinated for the flu, against the flu. You see on that bar graph here, the impact on quality of life, and the negative number here on that scale mean improvement in quality of life. Don't ask me why the scale is negative, but that's the way it works. Then a lot of these medications are known by some of you, known to be very effective, and reaching what we call the minimal clinical importance difference, as what the patient perceive have been important enough to change their life. Look at pulmonary rehabilitation. Those programs, it's double the quality of life improvement as compared to the medication. What is the best combination? Well, there's a debate out there now to know what is the best combination treatment. If I ask the question to physician, they're going to come and say, oh, is it the combination of bronchodilator or combination of bronchodilator with inhaled corticosteroid? And the debate is going to go on and on and on. This is not the best combination. The best combination is having the right medication and pulmonary rehabilitation. That's the best combination therapy for COPD. It's the best treatment that we have, pulmonary rehab, to improve functional capacity and exercise, as long as you keep doing exercise. Is it different than your medication? Your medication are effective as long as you keep taking your medication. It's the same thing for pulmonary rehab. This is to remind us that we're in Canada. This little green piece here, okay, then this is Quebec. And all the red dots are pulmonary rehab program. And this is a recent survey. It's the third survey that has been done in Canada. We keep increasing the facility for pulmonary rehab in Canada. But one problem is that we keep increasing the number of patients that have COPD. Therefore, only less than 1% of the patients have access to a pulmonary rehab program. This is at a sharp contrast with cardiac rehabilitation. Within a recent study in Ontario, 34% of the high-risk cardiac patients were referred to a pulmonary rehab. Huge gap. Access to pulmonary rehab. Referral, second huge gap. In a study done many years ago by a family physician across Canada, only 16% of the patients that the family physician were followed with COPD were referred. And trust me, that number is big. Those doctors are the ones really taking very good care of their COPD patient. They were interested enough to be in the survey for that reason. Despite that, it's only 16%, and 60% of those that have been referred have achieved. This means they have been in the program. That means, okay, that you end up with such a small number that are referred. What do? Second thing you do today, if you haven't had a rehab program as a patient, you ask your doctor. You don't accept an answer as, no, you don't need pulmonary rehab. That's not the good answer. You call the Quebec Lung Association, and you ask the Quebec Lung Association where there is a rehab program that I can go, or my physician can refer me, and then you call to that place. That's what you should be doing. Then you can educate the healthcare system. You have a responsibility. We all have a responsibility as a citizen in that society. You have a responsibility. Educate the healthcare system. Educate, okay, sometime your physician. What about education aiming at self-management, meaning having the right behavior that you can take your medication properly, you know the technique of breathing, you can recognize you have an exacerbation, taking a decision, you have the tool, okay, to take even action, proper action. This is called self-management education. And there's been, from this large systematic study, there's been shown very clearly a reduction of admission more than 40%, an improvement of quality of life that most of the drug study have not reached or would have liked to reach, because those are from randomized clinical trial here. This is compared to usual care. Where are the studies coming from? The landmark studies are coming from Canada. Like many new knowledge, efficacy, effectiveness study that have been done in many areas of COPD. Canada is a leader in that field and the respiratory field in general. Living well with COPD is known for more than 15, 20 years. The first study, randomized clinical trial, has been the first landmark study, have showed a reduction of 40%. 40% of the readmission rate, emergency room visit, and unscheduled physician visit. Join Living Well with COPD. It's yours. It's free. It's public. Create your access. You have, okay, to get to and Google Living Well with COPD. Enter, okay, on the website. Enter as a patient. Created your own ID, access number. Enter as a healthcare professional. And start playing, start going on, okay, the website. Bring that information, okay, to your healthcare professional, to your physician. Open the discussion with them. This is used extensively across Quebec in most of the COPD clinic, in many primary care facility and program, in almost all rehabilitation program. It's now expanding across Canada, and there is a lot of this used, okay, in many languages, okay, across the world right now. We don't have to prove anymore that it's effective. We have to prove how we can improve the way of delivering, of doing it better. But we have enough that we can start with what we have right now and improve the way that we are doing things as time goes. I'd like to finish by thanking, in fact, a lot of people. My institution, Living Well with COPD, which is almost an institution. Quebec Lung Association. Great, okay, to them. It's a huge and important resources. As I said before, you have a question, just call them. We're going to talk about smoking cessation. We're going to talk about nutrition aspect. All of that can be seen through the Living Well, but you can go to the Quebec Lung Association and ask questions. Industry are doing good things. And it's important to talk about the good thing. They're behind, they have the support, or this World Day COPD, they've been behind us, behind the Quebec Lung Association, thanks to AstraZeneca, and the most of all, thanks to the patient. Patient, family, friend, caregiver, thanks for your engagement. Keep engaging more. We need you. We can only help you if you're helping us. Remember that. Thanks, everyone.